I'm Dr. Farzan Bahin from Westmead Hospital in Sydney, Australia. I'm presenting this paper on behalf of my co-authors, Dr. Jayana, Hurigan, Lord, Whiteman, Williams, Lee, and senior author, Professor Michael Burke, on the long-term outcomes of a primary complete endoscopic resection strategy for Barrett's esophagus with high-grade dysplasia and early adenocarcinoma. Over the past 2 decades, there has been a paradigm shift in the treatment of neoplastic Barrett's esophagus, moving away from traditional esophagectomy towards endoscopic-based therapies. Endoscopic resection is recognized as being the ideal staging modality in terms of T staging for visible Barrett's disease, and subsequently informs the risk of lymph node invasion as well. There is a high rate of metachronous disease recurrence following endoscopic resection of Barrett's neoplasia, approaching 20 to 30% at 5 years, which makes complete endoscopic resection of the Barrett's mucosa imperative. This can be achieved through ablative methods such as radiofrequency ablation or resection methods such as EMR or ESD. While radiofrequency ablation enjoys the advantage of ease of use and low frequency of adverse events, it is limited by being purely an ablative therapy. It assumes 100% ability to detect subtle or covert synchronous cancer. It's not applicable in nodular disease, and there have been reports of post-RFA carcinomas. Complete endoscopic resection of the Barrett's mucosa provides the gold standard of comprehensive tissue acquisition and can detect covert synchronous carcinoma. The rationale for performing our study is to evaluate long-term outcomes of such an approach, as there is some data on short to medium-term outcomes. Our patients were referred to our centres with biopsy-proven high-grade dysplasia or early carcinoma in short segment Barrett's disease by Prague less than C3-M5. Patients underwent detailed examination by white light endoscopy, narrow focus, and also narrowband imaging, and had endoscopic resection by band mucosectomy of the most abnormal visible area, followed by contiguous resection of 30 to 50% of the esophageal circumference. 138 patients were studied out of 153 enrolled patients. Patients underwent complete staged endoscopic resection until all of the Barrett's mucosa was removed. We performed a validated dysphagia score before, during, and after endoscopic resection, and performed esophageal dilatation for dysphagia or an increase in their dysphagia score. Our results show that by intention to treat analysis, complete eradication of high-grade dysplasia early cancer was achieved in 99% of cases, eradication of any dysplasia in 89% of cases, and eradication of intestinal metaplasia in 71% of cases. We defined eradication as 2 negative endoscopic and histological examinations. In terms of adverse events, esophageal dilatation was performed in 36% of cases. The rate of bleeding requiring intervention occurred in 5% of cases, and in 1 patient, perforation occurred which was managed endoscopically without adverse sequelae. The majority of lesions were found in the 12 to 6 o'clock arc, and following CER, the histological grade was changed in nearly 50% of cases. Thus, our study confirms at mean follow-up greater than 40 months, a complete endoscopic resection strategy is highly effective and also safe. During our treatment period, covert synchronous cancer was detected in one patient, which adds to our hypothesis that endoscopic resection provides a unique advantage through its histological acquisition means. Stricture rate is a recognized problem, and therapies that prevent stricture formation after endoscopic resection are urgently needed to further refine the role of endoscopic resection in the setting of Barrett's neoplasia. We believe that complete endoscopic resection is a safe, effective and durable alternative to radiofrequency ablation and should be strongly considered as a primary therapy for patients with short segment Barrett's neoplasia.